Dr. Karamjit will be speaking first. Challenges in management of hard cataract during MSICS.
Uh, Good afternoon, respected chairpersons. So my talk basically it is very simple and it is a technique which I usually prefer to do in very hard cataracts. So age-related brown nuclear cataracts is more frequently seen in Indian population because of excessive exposure to UV light, invalid reason for postponing surgery, especially in rural and border belts of India, and inadequate access to health care. So operating on dense brown cataract often associated with pseudo-exfoliation syndrome in old age, complicated cataracts following uveitis and traumatic cataracts. So these are basically a great surgical challenge even for an experienced phacosurgeon due to high susceptibility of intraoperative complications with coexisting zonular weakness, endothelial damage and posterior capsular rent. So the goal of successful cataract surgery in dense brown cataract is to remove the lens while minimizing endothelial cell damage, avoiding wound burn if using phacoemulsification, intraoperative complications, and minimizing the postoperative inflammations. So MSICS, it is considered safe and effective technique and it is preferred over phaco for operating hard brown cataracts even by the experienced cataract surgeons. So I am showing my simple technique of tackling the brown cataract with manual small incision cataract surgeries. So you can see that it is a dense brown cataract. So in this type of hard brown cataracts, I usually do prefer to do approximately 6 sclerocorneal tunnel. So it is approximately 1.5 to 2 away from the limbus. So you can see that it is a reverse smiling incision that I usually give to ease out the nucleus delivery. So after this, I usually prefer to do a large capsular access from side port before entering the anterior chamber. In this way, the AC anterior chamber is maintained. So with the side port incision, it is very easy to do large capsular access. The capsule is stained with the blue dye. It is very well stained. So see the hardness of the nucleus. See the nucleus is shining. It is golden brown, you can say. So it is very hard and it is very difficult to tackle this nucleus with phacoemulsification, especially for the beginners. So once the capsular access is complete, then so it is advisable to enter the anterior chamber. So inner incision should be little bit larger than the outer incision. It is approximately 7 to 7.5 on, and it should be given on both sides. A gentle hydrodissection, because in most of the cases there is zonular dehiscence. So gentle hydrodissection is, and after that gentle nucleus rotation in one direction. Actually, if we do rotation in both the direction, then there are chances that nucleus can slip down through the dehiscence zonules. And after that, I prefer visco expression because I find that there is a minimal endothelial loss with visco when I am doing nucleus delivery with visco extension. So see the hardness, the hard brown cataract, and it is very difficult to do phacoemulsification in these type of cataracts, and gentle removal of the remaining cortical matter, and after that implantation of either foldable intraocular lens or we can implant 6 non-foldable intraocular lens, PMMA lens in this also. So I usually prefer this technique in most of the hard cataracts because most of the patients are from the border belt. They usually linger on their surgeries quite a lot. So these type of cataracts can be best tackled with the manual small incision cataract surgery. with little bit larger nucleus. So there is no harm because it is self-sealing. So there is no harm of giving large incision in this. So the carry home message is cataract surgeons must master manual small incision cataract surgery procedures to handle such type of challenging cases. Thank you very much for your patience listening. And I invite all of you to CCC 2025 to AI to All India Institute on 7 to 9th November 2025. Thank you very much.